What's that? Good. Well, welcome back. Thank you very much for staying, as I was saying. The committee meeting went after 2-3 hours. It gets to a little stretch if you bring it both days, 4 hours or more. We're right at the tail end now. And we had some outstanding meetings, talks, even discussions, questions. The purpose of this round table was, there were a lot of questions which were left behind. For example, there will be more as part of the discussion. So this is the time that we would like to bring it up. And I apologize first to Patricia. We are running, I as a chair and Igor decided to take a little break, 15 minutes break after 3.5 hours. So please, thank you so much for staying with us. And we will begin the round table starting with Igor.
Thank you. But Patricia, do you hear us?
Actually, if you could move a little closer to the microphone, that would be helpful.
Oh, okay. Okay, thank you.
Perfect.
So do you
Thank
hear
you.
us?
Perfect. Yes.
We hear you. Thank you. Thank you for participation. And look, I made a lot of discussion with people during our workshop, and they suggested us topics for discussions at round table. This is the questions. This is the topics you can see. And when if somebody would like to discuss any of them, just you can raise a hand and say something concerning on any topic. But as we agreed, we decided to start with the second structure racism measures. So Tyson, let's continue our discussion. Masood, I have a question. Somebody else had a question. I remember, and we have a question of our colleague in Zoom. So let me ask you. So look, let's assume we have Medicare data, yeah, and what would be a way to measure structural racism using Medicare data? So I would think, for example, that access to modern treatment could be difference in access to modern treatment could be such a measure. What do you think?
Thank you. Well, this disclaimer. This is not my field, but so I'd love to hear from. I'd love to hear from other folks in the audience, frankly, to discuss this, because I think that other folks here have expertise on Medicare data, but perhaps I could imagine looking at inequities in access, in quality of various forms of healthcare related to Medicare would be a great place to start, right? And I always advocate for taking a multi-faceted approach to measure these things. So ideally, I have more than one indicator, but I think that a great place to start would be looking at indicators of inequities, especially looking at it, particularly place-based inequities. So whether that be at the county level, the state level, regional levels, so forth, to look at differences in access and in quality. But again, this is my exact area, and so I would say it might be useful to talk to folks who actually have expertise on Medicare data.
Okay. So Masood, can you please read the question from
So Vito Di Bona asked, have you considered looking at structural racism domains at the county level?
Yeah, thank you so much for that question. Yes, I am working on that as we speak, and the aim is to link the state level and the county level to, and perhaps the regional level, to think about cross-level relationships in terms of their joint and potentially synergistic effects. Okay, so The short answer, yes, I'm working on that, and I think it's really important. I don't think that, I think obviously, we understand that structural racism operates at many levels, whether that be the region, the state, the county, neighborhood, within organizations. And we're really measuring the structural racism is really the infancy. We're just now starting to go beyond looking at measures of residential segregation. And I think that my hope is that in 5 years from now, we look back and we're in a completely different place. And that the state of the science is such that we are looking at this and modeling it as a multi-level phenomenon.
Thank you. So I maybe have a comment on this. So look, there are different kind of analytic methods capable to extract some internal structure in data. To me, we should use this kind of methods to try to identify unmeasured structural racism. Maybe latent structure methods, maybe something methods of factor analysis, maybe some partitioning approaches, comparison in different states. Does anybody has a similar experience to measure latent phenomenon like structural racism? No?
So, I mean, I'm an outsider to this field. I don't primarily work in Alzheimer's and dementia, but I feel like measurement is such a huge issue in the whole field. Like even the idea of cognitive decline is usually kind of, a synthetic measure where you're kind of drawing from a lot of measurements to get at some kind of underlying construct. So that's what came to mind when you asked the question.
Thank you.
So Larry, you were interested. Maybe we can further explore and discuss among the group. Would you like to kind of lead that?
Sure, I'd be honored to.
Well, I mean, when I raised my question, it was again with the interest of measurement, which is the subject of this topic, and the idea that time is a really critical variable, right? And that, so in my own analytic work with the HRS data set, Igor had a paper published in 2018 where he examined the diagnostic process over time. And what he showed was that if you measure cognitive impairment, it actually decreased over time, yet the number of diagnostic determinations of Alzheimer's and other dementias increased. So that's a paradoxical finding. And so time history itself, right, is an important variable to kind of factor into how we conceptualize structural racism, right? And so and in terms of, say we take interventions, we make interventions, how do we measure that they're working? And so an example that I didn't really get to finish because my mic was too far away was if you grow up in Savannah, but then you move to San Francisco, which is presumably a more tolerant place to live in terms of racism, does that improve things if we eliminated redlining, if we increased educational opportunity for young minoritized groups? Would that bring us over into the next level of addressing this problem? So that was my perspective.
Thank you. So maybe we discussed this point. Maybe we can, many people asked to hear opinion from National Institute on Aging and Alzheimer Association. Patricia, what do you think? Can you say a couple of words? What do you think?
Say that again.
This question, maybe on certain question, maybe workshop interview.
Okay, before I answer, I see there's a hand raised, Dr. Yashin.
Yes, can you hear me?
Yes, go ahead.
Okay. Yeah, first of all, I would like to congratulate the organizers beautiful meetings. 2 days of very intensive studies and discussions, and we see now that the field is moving in the right direction rather fast, and we also see the outline of new problems which are already partly addressed and still need to be further addressed. Concerning structural racism measures, structural racism from my point of view is a part of persistent stress which certain groups are experienced during their life. So this lifetime exposure to such stresses could generate so-called allostatic adaptation or allostatic load, which increase risks of many health disorders. And it means that we should develop models related, looking at longitudinal aspects of development of this consequences of structural racism, taking into account different kinds of measurement. And I'm glad that Medicare data are widely used because many people which are not were not familiar with, let's say, the wealth of this data criticize that there's a lot of noise in there. We know that's a lot of noise, and we also know that there are methods which could help us to avoid this, not to diminish this voice and select something which is useful, which is contained in this kind of data. So this is a very positive move. And I think that analyzing this structural racism as a consequences of persistent stress required stress-related models, and such models should involve several other components, environmental factors and genetic factors. And let me give you an example that the same, for example, the same stressor could produce completely different effects on two people which have different, let's say, response to the stress. Some people might have different perceptions of the same stressful event. And the way of perception depends on the past history of having positive and negative effects in the history of exposure to such kind of events. And it's related to genetics because it turns out that psychosocial stress is based on the mechanism of perception, which is a kind of emotional memory, which is written in human brain, in the part of which is called amygdala. And there are some genes responsible for such kind of memory. It's not genes which is responsible for Alzheimer's disease, but these are genes which influence the perception of stressors. And people who experience high level of stress, persistent stress, have high chance to develop diseases. People who are not have much lower chances. And what should be done then with this? If we develop understanding of such connection, and this is what people call gene-environment interaction, we will know which groups, with which kind of genetic background, what kind of approach are they supposed to get. Like in medical, people talk about personalized medicine or precision medicine. Any kind of help to eliminate structural racism should be also very personalized. We should understand specific situations, and we should understand how each person should be helped in this situation. So that's, I think, important component. And I'm very glad that in our group, because in BARU, in Biodemography of Aging Research Unit, we develop both directions of research. We develop longitudinal analysis, longitudinal model, which allows us to watch if we will be able to identify some particular structures in the population. We could be able to develop, to evaluate the future changes and evaluate the history of the changes if we have longitudinal data, like Framingham data, for instance, with more than 60 years of follow-up. And we also develop stress-related conceptual framework, which shows that, which give us a chance to link together genetics and environmental components associated with different kinds of risk factors associated with disparities. And I think this is also important directions of research, because not only Medicare data could be used, but also a lot of data about survey produced by surveys also could be combined with Medicare data. And methods, I will touch several additional points in this list. Methods are very important in this situation, because until now, there is no longitudinal model which takes into account missing data, informative missingness, and captures some hidden heterogeneity in structure related to structural racism. In our group, the methods of hidden heterogeneity and detection of hidden heterogeneity were developed maybe since 1979. So many generations of people already involved in this. And I think it could be some approaches developed to deal with hidden heterogeneity. And especially when more and more data became now available. So I think we are on the right track, and I think we'll have good success in the future.
Anatoly, would you like to say that maybe the theory of structural racism, I mean quantitative theory of structural racism exists, and we need to search respective model among models of chronic stress exposure, because structural racism could be considered like chronic stress exposure. So theories like allostatic load and so on.
Absolutely, absolutely. That's what I mean when I talk about allostatic adaptation, allostatic load. These are general terms. How this happens with people to different kind of unpleasant situations, and some people became robust because they learned how to deal with it. Some other did not become robust, and they will experience higher perception of stress and signals of danger, and so the stress consequences will be more serious for their health and survival.
Can we now move on to point number 3, opinion from
Point number 3, opinion from NIH and Alzheimer Association.
Yes, thank you. First, let me just say good afternoon. I'm Patricia Jones. I'm the director for the Office of Special Populations within the OD for NIA. And I just want to thank Igor and colleagues for the invitation to join this year. I've been listening to the conversation on both days. The topics that have been explored are hugely important. I cannot underscore enough how relevant the work is that you all are bringing forward and the questions that you're raising. They are obviously very important to Alzheimer's and other related dementias, but very germane to work that's happening across NIH as a whole. Many of you, I'm sure, are aware and have heard me and my colleagues address an initiative that's been underway for the last 2.5 years now called the Unite Initiative to address racial equity. The E in Unite speaks directly to the extramural component and looking more broadly at how our resources as a funder may influence the research activities that are happening in the extramural environment ecosystem. And that includes anything and everything from training resources to support the current and next generation of investigators and the skills and resources they have to leverage, to new important mechanisms to support other questions that we know warrant further exploration. But related to this matter concerning structural racism, I wanted to come back to a couple of points that I've heard as a theme, but I didn't hear explicitly touched upon. I just want to share a couple of points to consider. As we are discussing the utility of large data sets, I'm mindful that there are opportunities to mitigate for bias that may exist in large data sets. Yes, large data sets such as CMS and health insurance company data and other resources provide a broader and perhaps deeper reach to a population by volume, but there are some points to be mindful of, and I'm just encouraging each of you as quantitatively trained subject matter experts to take that point into your specific research activities as you're engaging and exploring the utility of large data sets and potential bias that may exist within those, and not necessarily assume that because those data are available through health departments or other resources that there may not be bias. The second point that I heard that reminded me of a concept that was originally developed in the HIV prevention research space by an anthropologist, Meryl Singer, in the early 90s, that seems very germane and relevant to the work that's being discussed over the past 2 days, which comes back to the point of syndemics. And as Dr. Brown's presentation set showed a slide that had two images of the United States where the deeper South states were in a dark blue coloring. That really reminded me and speaks to the overwhelming burden, additional burden of disease, irrespective of condition, whether it's diabetes, other chronic illnesses, or Alzheimer's or cancer, that all are particularly pronounced in those states of the US. And the opportunity to further explore the relationship of education and other upstream structural variables that may influence how syndemics plays out, not just from the perspective of intersectionality, because of course we hear people touch on intersectionality in the literature, but really from the perspective of additional burden. To what extent is there additional burden added on top of dementia and other factors? And then the third point I just wanted to underscore, as I'm listening to the conversation, I want to also encourage the researchers in this space here to consider opportunities to embrace the tenets of operational research. Oftentimes in our investigative activities, we're very focused on, of course, the treatment and intervention aspects and what we can bring forward as solutions immediately to the question at hand, but as a part of the process, and we're further exploring what processes help facilitate or serve as a barrier. I wonder if there's an opportunity for operational research to be leveraged to give better insight on evidence-based approaches on different models for teams, particularly as we're looking at how we can leverage team science, evidence-based team science, and other participatory research tenets and principles. I touch on that because a few times I heard the question raised yesterday and again this morning related to what can be done to further promote inclusion and to improve participation. And what I want to encourage the conversation to consider and embrace is an opportunity to revisit our models for how we structure our research teams and our decision-making processes, where we can better facilitate congruence and engage investigators that reflect and represent the lived experience of the very populations we're trying to engage, not just as a community advisory board member, not just as a core co-investigator, but in other facets and other roles and responsibilities where questions and approaches can be further explored with that eye toward the lived experience. So just want to encourage the inclusion of operational research to improve upon our strategies as a process. And then the fourth point I just want to note, I put in the chat, but I don't know if everyone was able to see their resources that are coming up in the next 2 weeks that might be of interest, particularly on March 30 at 2 p.m. The Research Coordinating Center Network, or RCCN, will be featuring a webinar looking at considerations regarding racial, ethnic, and gender differences in the context of resilience. The last investigator just spoke to looking at different facets that may influence personal medicine and precision medicine, and why some people excel and do well irrespective of negative life conditions and experiences, and why others may not. This particular webinar is intended to further explore that very question. And a busy day, March 30, as well as March 31, there's a 2-day workshop hosted by NIH, specifically looking at inclusive participation as a strategy with an eye toward improving clinical research. So I encourage people to consider registering and attending and participating in those conversations on March 30 and March 31.
Thank you. Thank you. Do you have questions to?
Thank you, Dr. Jones. I think there's a camera, you might have seen me a little bit on the side, but there was also.
I see your arm, but go ahead.
Those were amazing points, and I probably have comments on all of them, so I'm going to try to just pick one. And so I'm going to choose the one that I'm thinking about most right now. So I'm a new professor to UCLA, and I'm really interested in building a Black aging cohort in Los Angeles. There isn't one that's specific to the area. And I definitely want to approach everything appropriate, the most ethically appropriately way I can. And that includes building, an inclusive research team for, the community that I'm trying to engage. I don't just want to like, how do I do that? I mean, how do you
do that?
How do I find, I guess, the most appropriate people that are in it for the right reasons too? Because as I've come up through, this kind of probably a touchy statement, but as I've come up through academia, not everyone, as we know, is here for the right reasons.
Yeah.
And I genuinely care about the community. It's one of the main reasons why I chose to be faculty, was to make sure I can give back. So very long statement, but just a little background. So I was curious about how you might suggest finding the right people to help you support the work and make sure that they're coming about it, I guess.
I appreciate that. Thank you. Is that Casey?
Yeah. It's me.
Okay. Hi.
Yeah.
So excellent question that speaks to authenticity and passion and sincerity for the long haul. And I'm with you on that. Los Angeles is my home. It's particularly dear to me. And I just, I heard someone comment about living in different settings and assuming environments in California may be more receptive. That's not necessarily true. And that's part and parcel of the challenge, is that racism exists in many parts of the state. And I just remind people of Rodney King and the parts of South Los Angeles that have yet to fully recover from that experience 25, 30 years later. But to your point of identifying people with a commitment with authenticity, it's a challenge. And I'm happy to talk with you offline and put you in touch with some folks that I know have been at the table for a very, very long time and have street credibility, basically, and would be well received. But I come back to the point of participatory action research and those principles, where you see people consistently applying those principles, even when it's not popular, when it may not be well received. You see people staying the course and staying engaged, using the very principles that we see in the literature. That's usually a very good indication that that is truly their heart and passion, and they live by the very things that we have been preaching, practicing what they preach. And there are individuals that are certainly in that space that can help advance the science and the activities in the spirit of true partnership and collaboration.
Thank you. I have one question.
We'll talk offline. That's fine. We don't have to do it all today.
So, Carl Hill, who is another PI of this grant setting, is flying now. And he asked Casey to represent Alzheimer Association. Can you add anything? Do you have?
I mean, just so they can hear me. Just so they can hear me online, but no. My thoughts are my own. He just asked me, I think, just to be another voice potentially here. I do not represent the Alzheimer's Association. Maybe Percy Griffin is still online and might want to say something, but no, my thoughts are my own. Just want to.
Point noted.
Okay, so would you like to raise some question, to say something? For example, I asked myself, what would I like to discuss? And actually, I thought about the number 5. So we saw today different, today and yesterday, different type of geographic distributions. Geographic distributions means difference between states. This is geographic disparities in Alzheimer's disease. And we saw that measures actually are different. For example, we know that Washington State have a mortality from Alzheimer's disease is higher than in New York by a factor 3 or 4 even. This is just based on multiple cause of death data, based on death certificates. That's what we have in data. This is very stable effect during decades. I tried to look through the maps we saw, and we don't have any indication why this can happen. We don't have more prevalent cases in nursing home. I calculated incidence-based mortality. We don't have this distribution. This is almost flat if to see eastern and western states. If to speak in incidence-based mortality. And maybe you have an idea on this.
Unless there's someone else.
So fun.
Sorry, it's Casey Dieters again. This kind of goes actually to something that Dr. Jones was also speaking about. And so when I started in this research, looking at Black cohorts, I also noticed that everyone's paper would almost have somewhat different results. And so, when I think about geographic disparities and I started asking, how come they're not replicating when it's, Black people, right? And I think this kind of goes to something I also said yesterday that, the Black community is so heterogeneous in itself. So I think that is one aspect that we're not taking into account, but also I think recruitment methods. So when we think about the different cohorts we're using, that's something that I've been thinking about is just who's in our studies, like Dr. Jones was saying earlier, and could that be potentially, impacting the differences that we are seeing geographically? And I know this may not be the specific geographic disparities question you're referring to. We were talking about the mapping and stats, but these are just some things I was thinking about, and the cultural experience from each location as well.
You mean cultural among medical doctors to write specific diagnosis in this certificate?
Yes, sure. Everything, literally everything, every single bias.
Because of different medical schools.
Different trainings.
Yeah, I mean, that was going to be my point, that like, especially if you're relying on administrative data, health systems are different, health system norms are different, rules around how you document are different. Do you have time to even fill out the death certificate, or is it someone who's 3 links down the chain who's never touched the patient who's doing that? So if you're thinking about using this administrative data, you have to recognize how it came to be, right? It's not this nice, clean, beautiful thing that is consistent from, city to city, state to state, or even doctor to doctor. And that, when you're thinking about all these administrative data, that's why it's very dangerous in some ways to use it for these purposes. And we're trying to kind of drill down to very specific differences across any sort of categorizations.
And if I could just add to that point, that goes back to what I was commenting on with syndemics and just looking at the additional burden that may show up very, very differently for African-American or Black residents in upstate New York as compared to African-American or Black residents in Oklahoma. And what that epidemic, whatever the epidemic is, may look like, and the additional burden may map very interestingly to the broader investment and infrastructure or lack thereof based on that region. So all of those factors influence what you see manifesting in a given measure and has to be recognized, because it's not quite as simple to kind of neatly describe a phenomenon, to Casey's point about the heterogeneity.
Heather, please.
Okay, yeah, I was just gonna add to all of this that I think what a lot of this is touched on is kind of a fundamental challenge that we have for measurement in general in Alzheimer's disease, dementia, brain aging, because the main symptoms of the disease are cognitive and cognitive performance, and these are things that are contributed to by multiple, it's not the same thing as checking somebody's heart rate. Although you could say also heart rate is something that is a bad example, but in addition to that, I mean, I think that one of the reasons when then we try to get into inclusive research and understanding the disparities in this disease, the measurements, so what we have in the field, it feels, is a few really deeply phenotyped, really well characterized cohorts with synergized data across the 33 Alzheimer's disease centers. And that's wonderful, but they are poorly inclusive, right? And then on the flip side of that, we have these deeper, and this is something that Dr. Jones was saying earlier, the flip side of that, when we try to get more really broadly representative data, we get into these problems where the fundamental things that we want to measure, like, did the person have dementia? Was dementia a cause of their death? What was their cognition? Those things are really, really hard to get at from that data. So, I mean, I guess one of the things that I would say that may help us is I think that if we start to develop reliable measures or biomarkers that are more easily attainable, this might help move us forward in addition to recruitment science and operational research to increase the inclusivity of those more deeply phenotyped populations.
Yeah, I would agree, I think in the interest of the time, I know you appreciate. Number 8. Right? Factor.
Okay, let's consider number 8 together with number 4.
Okay.
For losing.
If I could just use a little bit of privilege and just encourage us as we're thinking about number 4 and number 8 to just be mindful. I've heard a number of folks cite the NIH Health Disparities Research Framework. Many of you may be aware that it has been adapted and used pretty consistently by our sister institute, the National Institute on Minority Health and Health Disparities. I encourage, as we're looking at these broad, multifaceted questions, that we be mindful of this tool and not necessarily fixate on one approach, one measure, one domain, that these things are very much intertwined, and that framework as a conceptual framework could be of utility in helping us think about malleable targets that may straddle many different levels and many different domains.
My point is, I think, related to about the previous point, I think, about measurement. Yes, I think measurement of Alzheimer's disease related dementia should be better. And also, I think we don't use very good measurement for independent variables as well. So, for example, social engagement. Social engagement, many people say social engagement is associated with development of dementia. So we conducted systematic review on social engagement. Social engagement measurement is really, really awful. It's everyone uses, different definition. So like I showed in my research, maybe giving diagnosis may be different depending on who is receiving it. So I think we have a lot of things to work on to have better measurements on both dependent variable and independent variables aspect.
Okay, so I wanted to address Mustafa's question number 8. This is actually my favorite topic, and I think I've nailed the answer. Of course, you can all disagree with me. Okay. But Percy Griffin, he brought up something that extremely impressed me, which was he noted that exposure to discrimination results in lower memory scores. Okay. All right, so we're talking about discrimination here. So there you automatically have a baseline lowering of their cognitive scores. Okay. The second point that I thought was very important was the influence of blood pressure as a risk factor. Okay. Now, Tyson put up a paper, one of which a co-author was Norman Anderson, who used to be here at Duke and then went to the APA organization. But he was very seminal in demonstrating the role of hypertension as it relates to discrimination, right? So here we have two extremely important variables, which is the chronic stressor that Igor has mentioned in terms of the results of discrimination. We know that this can result in an increase in blood pressure, which can lead to strokes, other complications in the brain. Okay, so then the third thing that came out, particularly yesterday, was the influence of education, right? That also influences scores. I'm a neuropsychologist, by the way, so this is my bread and butter. So what I would like to suggest is these are the three most important factors in determining impaired cognition and lowering scores. So I would raise actually the hypothesis that the difference in racialized scores is partly due particularly to education. And this was brought up yesterday that in neuropsychology, it's very difficult to factor in the results of a poor education in terms of its influence on the cognition score. In fact, we talked about adding points to the MMSC to compensate for this. But I would maintain these are the three most rank ordered factors that are important in what we're seeing.
And you're saying the three would be education, discrimination, and what was the third?
Well, blood pressure, the
Blood
results.
pressure, cardiovascular. Yeah. So Lisa Barnes' work, I think, would support looking in that direction, taking into account those factors. Yeah.
Yeah. Thank you. I'm
Several other questions.
oh
They're all very interesting, but with all due respect to our keynote speaker, I think I don't want to chew into her time. And if it's okay with Igor.
yeah, that's okay. That's okay. Yeah, we have exactly time of our end of round table. Let me thank you. Patricia, thank you for participation. Please stay with us for our
Thank you for having me. I'm
keynote
happy to stay on.
presentation if you can. So let's have a last presentation.
And as you're preparing, I'll just close out by saying I'm happy to have conversations with anyone beyond today. Feel free to reach out to me.